Welcome back to Rural Health Today. This episode is another installment in our season on maternal care and rural health, where we're talking with maternal health experts about rural maternal morbidity, genetics, mental health, and more to understand the barriers to proper maternal health care in rural America. I'm excited to introduce our guest today, Carrie Cochran-McClain, Chief Policy Officer at the National Rural Health Association. Now, for many of you folks, it's affectionately called NRHA. I have been a major advocate for NRHA and the work that they do. We've had policy experts from NRHA on. We've had senior leaders. It's always a pleasure to have Carrie. She is phenomenal to advocate for rural hospitals like Hillsdale across the country. And she brings a depth and just a long list of accomplishments and a depth of knowledge that's really second to none in working with rural hospitals. Now, she may or may not share this, but from Montana, where we understand you can get pretty rural in Montana. Carrie's going to share a little bit of a neat fact about herself, her life, her job, whatever she wishes to do. But it is my pleasure to have in the studio with me today Carrie Cochran-McClain. And as a Chief Policy Officer, you can only imagine that these are probably busy times for Carrie, because there's a couple things happening at the national level, and respective states are passing all kinds of stuff from, nurse staffing ratios that impact rural hospitals to 340B, impact on that, to the national issues that we face today beyond that, which is the Medicaid and Medicare. Now, to the chagrin maybe of her, we're not going to get into all that today. We're going to save that for another discussion, because today we have a very important topic that we're going to talk about. But before I do that, Carrie, it's always great to have you. You've been on Rural Health Rising. You've been a guest of ours before, and we've promoted you. And at every conversation that we have with you, we're learning new and innovative things that the NRHA is doing to really advocate for rural patients. Now, I know your advocacy is truly about hospital representation and providers, but at the end of the day, you're advocating for rural patients. So first of all, Carrie, tell us a little bit about your role at NRHA. How long have you been there? What brought you to the organization? And maybe why did you choose this field? And then from there, we're going to follow up on some very important questions.
All right. Well, thanks so much, JJ. And it's always my pleasure to join you all. You guys do such fantastic work, both at Hillsdale and then with this podcast. We really appreciate the opportunity to lift up kind of rural issues and have such a strong rural voice like yours in the field. So
thank you. Thank you so much.
Yeah. So in terms of NRHA, so I have been at NRHA about 4.5 years. My role here at the association really is to take our collective member voice and bring that to Washington, D.C. as we aim to set policy and influence policy that impacts our rural communities and the populations who live there. So I have, like I said, been here since I came in 2020, and prior to that, the bulk of my career was with the U.S. Department of Health and Human Services. I actually started my federal career many moons ago in the Federal Office of Rural Health Policy. So I was there for quite a while, and I got to serve as Tom Morris's deputy before I moved into a different part of the agency. But lucky that the federal office, I found FRHP. I was going to just be in DC for a year and head back to Montana, and I found FRHP, and it was just such a natural fit with my interest in healthcare and just really the importance of having access regardless of where you live and what your zip code is. So it's been a good journey.
And wow, what an exciting career. And Tom, now is he still head of the agency?
He is still there.
That's what I thought.
We're holding on to him with dear life.
Exactly. It's very important. I had the chance to come to DC several years ago, had a chance to meet with you. And then we, in DC, we did meet with Tom, and just, wow, what an incredible guy. And Tom was actually up in Marquette, Michigan about a year ago in some projects up there working with rural hospitals. And, as we know, many voices need to be lifted up at this time that we're living in today, because one of our voices lifted up helps those rural communities like Hillsdale. And so when we lift our voice together in unison, it can have a powerful impact. And you watch that every day in Washington. We're going to talk about that, how it transcends from Washington to Lansing, here at the state level of the work that you're doing. We'll get into that in just a minute. But for our listeners who may not know Carrie, okay, they just heard a little bio about you, right? Extensive career, great. But do you have like a fun or interesting fact about yourself, something where someone would go, that's pretty neat? And I'm assuming you do. And could you share with our listeners today to get to know you just a little bit better?
Sure. Well, I have been in Washington, D.C. for far too long, doing good work, but here in a pretty densely urban part of the country. But I am lucky in that my house, I live in Washington, D.C. I live on Capitol Hill, which is fairly rare. And I happen to live on a block that has a wonderful community garden. And I recently joined the community garden as a board member. And I have my plot, and it is my chance to hold on to a little bit of green space here in the concrete jungle and feel a little connection with home. So I am a closet gardener, not a very good one, but I still like digging in the dirt.
Well, that's incredible. That is incredible. Well, certainly in your home state of Montana and here in Michigan, it's all about the outdoors. And, we have plenty of opportunities to explore. And sometimes, Carrie, when things get tough like they are right now in Washington or for us in our state in Lansing, it's kind of nice to connect. I was speaking with one of my colleagues who's a CEO of a small rural hospital, and, she rides horseback. And she told me that, just what a half hour can do on the back of a horse as she's riding the fields. And I think in leadership, it's so important that we take these breathing moments. Wouldn't you agree, to really just focus? Because there's a lot of negativity out there. There's a tremendous amount. And I think as leaders, we really have to find where is that going to be that we can renew and find some strength.
I think every time it feels like I sit down at my computer or look at my phone, there's a new challenge, you could say opportunity, but I'm going to, I think realistically a challenge it feels like for us to be dealing with, especially right now in these times. And, that anxiety noise at the back of your head is real. And it is very helpful to take a moment and just kind of center in whatever way brings you peace. And so, thankful for that.
That's right. That's right. Very important. Very important. Absolutely. So, before we get into the topic today, and I know my producer's like, come on, JJ, we got to get to the topic, is really discussing, for our listeners, we like for this podcast to be current as well. And, of course, there's a lot of issues that, you're tackling right now in Washington. I had dinner with the American Hospital Association president, Rick Pollack, a few weeks ago. And, Rick had shared a comment that was, very interesting. Rick's been in the business for 40 years and worked in multiple agencies. But he said, Washington is just different today. It's transactional. It just doesn't feel the same. And so I guess, as you look at your organization, Carrie, just for our listeners to know, what percentage, you rely on some federal funding, grants, pass-throughs, those type of things. So let's give a plug for your organization and what can our listeners do to support you in lifting their voice to their congressional leaders to say, here's a couple issues we need to protect. Do you have, and again, I know it wasn't scripted, but do you have, some advice you can give to the listeners who want to support you?
Yeah, I really appreciate that, JJ. I think I would say that whatever your issue is in the rural space, it truly is all hands on deck right now.
It is.
We are very focused on reconciliation and the conversations that are happening that are most likely going to bring some level of cuts to Medicaid, although we're not sure in what way and how much. But there are other areas that could be also impacted, whether that's marketplace subsidies or changes to the Medicare program. There's a lot of unknowns in the reconciliation space. And then we saw last week a leak of the what is likely to be pretty close to final FY26 president's budget. And it didn't look good for a lot of folks, including rural, and some cuts to our real core programs in the rural space. So we are asking everybody to take a moment and raise your voice to your members of Congress. I will say also to your state leadership, having governors and legislators put the pressure back on the federal government and Congress as we're talking about these cuts that'll put a lot of pressure on states if that funding goes away. So
it will.
I would say that you will be helping us immensely if you can help tell that story and just help us make noise about how important this is for rural.
So our listeners across the country, and we want to take just a moment to ask you to reach out today, next week, and trust me, the timing of this is critical. We're hearing as soon as next month that they're going to have this reconciliation conversation, and from there it's go. And we don't know if it's going to be immediate effect or how they're going to, really take this 10-year approach. But if you're listening today and you're thinking about, what are ways in which I can help my local community, advocacy. It's said best when we say politics today and advocating for rural hospitals is not a spectator sport. You have to be involved. We are in a situation where we're the third largest employer. We are, and you'll find your rural communities, your hospitals are 1, 2, 3, the largest organizations and the largest employers in that area. And then the concern, of course, we did see the leak of that budget, and it's very concerning for rural in many areas, not just because of Medicaid, which in and of itself, an $800 billion cut on the backs of hospitals and providers is not sustainable. But beyond that, our core programs that we utilize in USDA, core programs that we utilize to fund programs through pass-through at the NRHA and other things that are very important and vital to the position and role of supporting and uplifting rural health. So you heard it here today officially from Carrie, who does this for a living. She goes to Washington, and God bless her for doing that, because it's not a place that a lot of folks like to go. But she goes there, and she's doing it to advocate for you, the listener. So you're in, let's say, I received an email last week from someone in Arizona, and if you're in Arizona, at the end of the day, you know that those issues are just as real in Arizona as they are in Michigan. The last point I'll raise with Carrie's point, we did some modeling at MHA. I'm a board member of the Michigan Hospital Association. We did some modeling. The impact to local hospitals are so devastating that when we had Scott Becker on the podcast last week, he shared with us that 800 hospitals are at risk of closing. And that's going to be accelerated if these Medicaid cuts come through. It's going to be even higher than that, and it's going to be immediate for many of those hospitals with little cash on hand. But, to understand the complexities of this, when the government shifts what we call the provider tax to those states that expanded Medicaid under the ACA, what we know is Michigan's going to have to come up with over $1 billion, with a B, $1 billion. Now, there isn't even $1 million extra dollars in the state budget, let alone $1 billion. So what we know is these cuts are going to be on the backs of hospitals and providers, and that's going to be devastating. So I know I've been talking about a lot, folks, and you may be tired of it, but what we have to do is we have to put enough pressure and noise on our representatives that they can't say when they're making that vote, well, I didn't hear from any of my constituents, so I guess I can place that vote. They need to be thinking about the thousands of people that have reached out to them to say that this is harmful. And so please do that. For our supporters on the other side, we'll not forget about them. And this is by and large becoming a partisan issue. So there's the Republicans and the Democrats. So there's a lot of Democrats that are supporting it. We just had 12 Republicans come out Monday, which I'm encouraged, opposing these cuts, which I'm very excited about that. We need more of it. But also call those that are supporting our efforts. When you think about Democratic leadership, we might not all agree on all the issues, but if they're supporting rural, you need to let them know that you appreciate them, because you can't just be talking about the bad. They need to be encouraged as well to continue the fight, because it's a fight today, folks. So you heard it directly from Carrie and JJ. Let your voice be heard. It is not a spectator sport. But we move on, because this is our third episode of Rural Health and Maternity Care. And that's our first season launch of our new podcast, Rural Health Today. So between birthing center closures, which we know have been numerous, one just 25 miles from me, and then several after that closure within an hour radius have closed. We know that those closures have impacted rural communities. We know that harmful legislation also has impacted the quality of care that can be delivered in rural communities. Maternal health care seems to be deteriorating in rural America. And Carrie is here to share her perspective and insight as an expert in the impact of policy on rural health. How do you utilize policy to make sure that we can avoid some of these very dangerous situations in which closures exist? So today we'll talk about maternal health care deserts, rural vulnerabilities, and of course, what it all has to do with rural health. So let's get started. I want to build a framework today, okay? And in order to do that, I want to start with the foundation of where are we at today. Let's paint the picture. So can you tell us what our current state of maternal health care in rural America looks like, Carrie? And what should our listeners know before we dive deeper into some very key topics, like just in general?
Sure. Well, I think access to care is not a new challenge in rural areas.
Right.
And when you look at this issue, we were talking about challenges in accessing maternal health care back in the 90s, and unfortunately, that situation has continued to deteriorate, and I know it is deteriorating at an alarming rate from my perspective. We've got over half, about 60% of rural communities, rural counties throughout the country lack hospital-based obstetrical services. So 60%. Yeah. That is almost 2/3, depending on how you do math. That is a lot. And we know that the bulk of the parts of the country that are considered maternity care deserts are located in rural areas. So this is a real issue for us, and it's a growing issue for us. In 2010, there were about 42% of rural communities didn't have obstetric services. Now you fast forward 15 years, and we are already up to 60% of counties not having those services. So that's a significant jump in a not very long period of time. And that can cause all sorts of implications, both in terms of travel times for women and their families. We also know that rural women tend to have some complexities associated with pregnancies, and getting kind of access to the prenatal, postnatal care that's associated with that is really important. And if we lose that obstetric capacity in our rural communities, we lose kind of that ability throughout the whole pregnancy cycle to be able to take care of women.
Absolutely. Those numbers should give individuals a pause and concern, because that is not a good trend at all. And unfortunately, when we talk about some of the financial burdens and the shifts, the likelihood of those numbers going down anytime soon, probably slim. And in fact, those numbers probably are going to continue to go up unless there's some significant advocacy and intervention that goes on. And let's speak about that, because you're part of the NRHA leadership team. You have witnessed throughout your entire career, both at the NRHA and before that with the department, lows for rural healthcare. There's been times. One of the worst lows we've seen in the past decade is expanding care deserts for maternal health. And I guess, what are you seeing in terms of labor and delivery unit closures right now? We talked a little bit about some of the access issues, but what would you say, as you're doing the research, is a cause for the unit closure? And when that happens, what does it do? Right.
So I think that there are, I think at the crux of a lot of our closures are a couple of issues. One, we know that in all of rural healthcare, but obstetric care in particular, we have a lot of places in this country that have lower birth volumes. And that is partially just because of the populations who are living in rural areas and how those demographics are changing. Part of that is kind of where people are choosing to access care when they need it. But when a facility has a lower birth volume or a lower volume of services, it means that they have all the same costs associated with providing that care, but it is spread over a fewer number of visits, and kind of that reimbursement needs to be made up. And it is hard to do that at the current reimbursement rates.
Yes.
Medicaid is by far the largest payer of for births in rural areas. Everywhere from 50% up to, I talk to facilities pretty regularly who have 90+% of their births are Medicaid births.
Yeah.
And Medicaid on average pays half, if we're lucky, of commercial rates.
Yeah,
for commercial
lucky.
rates. So, you're not getting reimbursed for what you need.
No.
And you already have higher costs because of, those fixed costs and lower volumes. So that is, I think, one of the primary drivers. I will say, another big challenge is the workforce availability to support labor and delivery services. We don't have as many OBs in rural communities. We're much more reliant on family physicians to provide labor and delivery services, and they do an excellent job of that. But again, when you're not doing a lot of births, you still have to keep your skills sharp. You still have to have your care team that is very comfortable doing labor and delivery. And that can be really challenging. And getting folks who are able to do that and want to do that in a rural setting, and making sure that they have the support they need when they get into a situation where they have a higher risk birth. All of those things add a layer of complexity. Mm-hmm. And then I will say, you said it very well. Our rural hospitals across the country are struggling. We have nearly half of rural hospitals operate on negative margins. They have negative operating margins. And I'm not an operations person, but I can tell you that negative operations or negative operating margins means that you have some hard choices ahead of you.
You sure do.
And one of those increasingly common choices is to close your obstetric unit for all the reasons that I just mentioned.
Yeah. And, as we see that's typically the number one place where administrators go to cut, because as you indicated, it's a disproportionate number of Medicaid patients as a comparison to your other service lines. So, for example, here, between the federal government, between Medicaid and Medicare, we're about 70% of our payer mix. On the hospital side, roughly 30% is going to be that Medicaid, just right around 30% Medicaid. But when you get into OB, it's double that. We're talking 60 and 70% of the patient population's Medicaid. And in a community like ours, in a state like ours, Medicaid has had zero increases since 2001. So for 24 years, while at the same time labor's going up, the cost of materials are going up, recruitment costs are going up. Let's talk about nurse wages, right?
Yeah.
Since the pandemic, they've exploded. And you look at all of those, but at the same time, payers, specifically Medicaid, because that's a higher population in rural, have not increased their reimbursements, which means, and we had a presentation from Laura from MHA, who talked about the equivalency would be 1968 payment models that we're operating on today. In other words, that is, if you to look back at the state budget with inflation, that's how we're operating today under reimbursement models. And so with cost as expensive as they are, this is very difficult for rural hospitals. So one of the tough choices that hospital executives have to make is, do we keep our ER open? Do we keep our critical care unit open? Or do we close those, and then that's going to risk heart attacks, strokes? Or do we close obstetrics? And oftentimes they go for OB and psych services, which both we have here. And both of those recently have lost money for this hospital. And you can only operate in a negative margin for so long, where you eat your cash on hand and then you're done. So those discussions are happening. So I guess that segues great into this question. How does policy change all this? Because at the federal level, you're dealing with policy every day. And some policies, are pass-throughs at the federal level to the states. We think about OB stabilization money. We think about the provider tax under Medicaid, which is maximizing CMS at the federal level. But how does policy, Carrie, impact all of this? And I guess as we look at the policy, Tell us about the Rural Obstetrics Readiness Act and other legislation that impacts maternity care.
Right. Well, this is, I will say, a tricky issue to get at the federal level because of what we just talked about, Medicaid being the primary payer. And
Yeah.
Medicaid, a lot of Medicaid rates and Medicaid policy is set at the state level. So for us to be able to influence nationally kind of Medicaid policy, it's a pretty significant political lift, especially in times like these where we are just fighting to hold on to what we have in the Medicaid space. Conversations about making kind of increases to Medicaid, whether that's kind of around reimbursement or around some other kind of way to enhance services. That's a hard conversation right now.
Mm-hmm.
I will say it is, from my perspective, one of the only ways we are going to get out of this because we can do everything. We can try all sorts of things around the edges to make sure we have the workforce there and to make sure that we have grants for folks who are in dire need. But at the end of the day, we really need to be able to tackle the reimbursement challenges. So, we have seen a couple of things come out of Washington in this space. Last Congress, there was a bill that was introduced by Senate Democrats. It was not a bipartisan bill, and we here at NRHA really try to endorse bipartisan only legislation because realistically those are the pieces of legislation that are going to move. But we endorsed this piece because it really was specifically focused on how do we increase and access to obstetric care in rural areas,
Mm-hmm.
and that it had some focus on underserved. So it did things like increasing Medicaid reimbursement rates for labor and delivery in rural, creating standby payments for low volume hospitals to be able to sustain obstetric units, and talking about things like the postpartum Medicaid coverage, which a lot of states have already moved to.
Mm-hmm.
So, it's going to take political will, but that is one potential route. We also have seen conversations like the Transforming Maternal Health, the TEMA demonstration that came out of CMMI. That was a demonstration announced last year that went out to a dozen or so states to really think about how you can use population health and use value-based payment to manage your maternal care. And they had a rural specific track to that demonstration. So we're hopeful, one, that demonstration continues in this administration, and two, that we have some good lessons learned from that maternal track or maternal kind of focus or the rural focus within that to try to kind of figure out how to tackle this challenge from a reimbursement standpoint. While we're working on that, we are very much trying to get, like I said, resources to facilities that are in pretty dire straits. So you mentioned the Rural Obstetric Readiness Act. Mm-hmm. This program is specifically for facilities that have already given up their OB services. So I know it is not the answer.
So that's the key. Okay.
But we are hearing about all sorts of difficult situations that hospitals find themselves in related to obstetric emergencies, whether that's precipitative birth and you have someone who's doing an emergency birth in your facility, or challenges with prenatal or postpartum care. This program is a new grant program that we have been successful in getting introduced in last Congress and again in this Congress, that would provide training, equipment, and teleconsultation support for emergency obstetric care. So that's like kind of your worst case scenario situation. Yeah. How do we make sure that in emergencies, hospitals are prepared? But we also have programs like the Our Moms program out of the Federal Office of Rural Health Policy, which is a demonstration program that's been in existence for the last 5 or so years that really help regions of parts of states come together to figure out how do they improve rural maternal health outcomes by creating networks, by working with our state Medicaid program, by using telehealth, and doing some innovative solutions there. Again, that's a small program. They're able to fund 2, 3, 4 grantees a year. for 4 years at a time. But it's another kind of piece in this puzzle where we're really trying to find solutions that work and then figure out how to scale that at a national level.
Carrie, what's interesting, you brought up several important things that I just want to touch on real quickly, and I know time is escaping us, but, you mentioned like low volume adjustment, LVA, we talk about disproportionate share hospital, we talk about OB stabilization, all these programs, collectively bring just enough with the Medicaid and for that Medicaid uplift to barely cover, the cost of delivering service. And in many communities, all of those programs added up get us to a point where it becomes part of a smaller community benefit. We're still putting some contribution margin back in, but it's not as heavy if we wouldn't have had all those programs. But I think what we have to realize right now, where we're seated, having a peak view of the president's budget, knowing what they're going to do in the commerce budget with $880 billion, Carrie, all of that's on the line. So we're going to only, and I'm an eternal optimist, okay? But what that's going to do is that's going to have some very negative, very quick, impact on our community hospitals. So we're going to pause right there before I ask the next question, which will be our last one, and really ask, given this is not a spectator sport, for the person listening that says, what, my voice doesn't matter, you got to tell us what is important here. We have got to change course right now. And I don't think it's too late. They have not come to reconciliation yet, correct?
No, they have not.
So with all of the knowledge you just gave us that we're already struggling with the programs that are already in place, LVA, DISH, all those things, now we take all those away, this problem intensifies. What can the listener do today?
Yeah. So, there have been, again, kind of going back to where we started, we really need the listeners, whether that is a hospital administrator, whether that is a clinician, whether that is a patient, to be contacting your members of Congress, and telling them the important role that Medicaid plays in your ability to provide care, receive care in your rural community. A lot of the proposals that are being discussed, you'll hear people say, well, it's not going to impact the traditional Medicaid population. But JJ, to your earlier point, if you start taking away things like provider tax, which is a sticky issue to explain, if you start taking away that shortfall that states are going to have to be facing, there is no way that states aren't going to have to look at cutting eligibility, cutting services, cutting reimbursements. I mean, they only have so many levers to be able to make the budget whole at the end of the day.
Or increase taxes.
Or increase taxes. So, you hear a lot of the conversation right now being like, we're going to protect the traditional Medicaid population. We are applying work requirements that won't impact people who are really at need. We are, we're getting rid of provider taxes that are double dipping into the system.
Yeah, gaming the system.
There are all sorts of things and sorts of ways you can frame it. But at the end of the day, $880 billion taken out of Medicaid is going to be impacting the care that we receive in our rural communities. And as you and I both mentioned earlier, rural areas are disproportionately reliant on programs like Medicaid and Medicare. So we are the ones who are going to be hurt the most by these cuts. And I honestly like to give the benefit of the doubt and do not think that members of Congress really understand that by taking this payment out of Medicaid, they are harming a very vulnerable rural healthcare infrastructure. And we have to tell that story.
We do, and give consideration to the senior that has Medicare and Medicaid as a supplement. Absolutely. And, a couple issues that we can tackle very quickly are waste, fraud, and abuse. That becomes their go-to. And folks listening today, there's not enough waste, fraud, or abuse to get us to $880 billion. Understand that some of the scare tactics being used to try to justify this are things like 27-year-old men sitting in their parents' basement playing video games. Let me tell you something. In the state of Michigan, it is very difficult to get Medicaid. You go through a very extensive application process. Let's say that there is a 27-year-old male sitting in his parents' basement playing video games. That number is very small, very small. And yes, if there's waste and fraud going on, then let's deal with that. But on the backs of hospitals and doctors and providers, we cannot do this because the cuts, you're still going to have a Medicaid card. Hear us now. If you're a Medicaid recipient, we are not using a scare tactic. They've made it very clear from the president to all members of Congress, everyone wants the Medicaid program. So you're not going to hear them talk about cutting the Medicaid program. What they're cutting is reimbursement to hospitals and providers like my doctors in this community, taking us back to 1990 reimbursement. We cannot deliver the level of services necessary to our population and receive a fraction of the reimbursement. It just doesn't work. And so it's not eliminating the program, but it is eliminating the reimbursement, which means, yes, you'll have a Medicaid card. Where are you going to use that Medicaid card? Because your community hospitals are all closed. You will drive 2 hours, 3 hours to a tertiary center, a large facility. And you know what's going to happen? People are going to be boarded in the ER for weeks. Individuals will not receive the care they need. Individuals that are having heart attacks and strokes, we say time is tissue in this industry, will die. And this is not fear tactics, fear mongering, as we've been hearing about. This is about real life and death issues that we're impacted with. So you'll have a Medicaid card. There just won't be any place to use it. So it's the equivalency of the government going out, buying you a car, but then telling the gas stations that they have to sell gas cheaper than they can buy it for. Gas stations will not be in existence, and you're going to have a pretty shiny car, just like that card that sits in your wallet. The car sits in your garage, but you have no gas to use the car. So you'll have your Medicaid card. That's a given. However, the availability to have a provider in your community will be gone. Your hospitals, as Scott Becker said, 800 are at risk of closing and will close. And of those immediate risk, over 300 immediate risk, 20 of those are identified in the state of Michigan. This is what's going to happen. Care delivery models will be compromised. Quality of care will be diminished. Access to care will be eliminated, and patients will suffer. This is why we have to let our voices be heard today before reconciliation happens, to hold our elected officials accountable for the priorities which are important for rural communities like Hillsdale. Let's not even talk about the economic engine that these hospitals provide in their local communities. I won't even get into that, but we do. And it's contributing tens of millions of dollars back in the local economy every year. The impact to this is far reaching, just even beyond healthcare. It goes into the economies of those communities, the wellness of those communities, the ability for those communities to attract businesses, and the list goes on and on. So you heard it from us. These are programs right now that are benefiting our community hospitals, but they're also programs that, if eliminated, will cause the closure of those hospitals as well. So, Carrie, the next question is, what's next? Let's say that Medicaid doesn't engage in, let's just say the federal government doesn't have the degree of Medicaid cuts that we think are coming. All right, how can a hospital link up with you and your organization to engage in programs like you've just explained? Is there a mechanism? Is there a way to do that? Maybe there's a community hospital listening today that didn't even know about some of these programs, and they're really struggling. What resources are available to community hospitals and leaders?
Absolutely. Well, I will say, come talk to NRHA. That is what we're here for. We have, if you're a website person, our website, ruralhealth.us/advocacy, has all sorts of tools for you to be able to talk to your member of Congress. JJ, I growing up in Montana, I would have never thought that this would be my job. And I still, every once in a while, feel like am I sure that I should be the person talking to this member of Congress about this issue?
You
We
do a
all feel
phenomenal
that way.
job.
We
Yeah.
all feel that way. So don't be
Yeah.
intimidated. These
Yeah.
people are here to represent and make policy on behalf of you as their
Yeah.
constituent. So we at NRHA do everything we can to bring you the tools and make that as easy as possible. So our website, ruralhealth.us/advocacy, has tools. We have fact sheets, we have talking points, we have a campaign where you can go on and just type in your address and it'll automatically pull up your member of Congress, and you can use our self-populated message or write your own message to let them know kind of how you're feeling about the issue. You are also, we have regular communications that go out to folks to keep them updated about what's happening in this space. We do calls. You can email me directly. We really are in a place where it's all hands on deck. So our website is probably the best way to initially access us, but I will make sure that JJ and team have that, and maybe can put that
we'll
on
put it in the show notes. Absolutely.
Show notes. And we just really, really encourage you to help us tell the story of how important this is to rural America.
That's right. And you know what, Carrie, I always brag about you. Wherever I go, I was just bragging about you to Adam Carlson and Laura Apple, who, work closely with NRHA as MHA members and AHA. And I brag about you because you're doing missionary-minded work. You really are. You're advocating for rural hospitals, lifting our hospitals up. I can't get to Washington. I can't. It's so busy here and busy in my own state fighting some of the issues.
I mean, we need you where you are.
Right. And that's why your voice is so important. And I couldn't think of a better voice, and I'm being sincere, to have than yours. We're very grateful for it. And people that I speak with across the country, when they talk about, how do you advocate? How do you do it? I say, get a hold of Carrie, and I do. And I say, get a hold of the NRHA, because I'm telling you, at the end of the day, they will be our voice. It's important to be a member of the NRHA. If you're listening today as a executive of a hospital across this country, you have a great opportunity to have a team of professionals at your side who will advocate for you. I get alerts all the time. You send out the NRHA alerts. We have an online forum. I get a lot of emails. I can tell you that. And there's a lot, but it's good. It's good. There's always a lot of input. And it ranges from a variety of topics that are very important, to hospitals like mine. And then when there's action alerts, you send those out. And NRHA has a conference. They have training programs. There's just a whole list of things. I'd encourage you, if you're listening today and you're looking for a resource, your state association is important, but NRHA for rural hospitals is equally important, and we find them to be good partners. So, Carrie, it's always a pleasure to have you on the podcast. I do look forward, hopefully, in the months ahead, to have you on and have some better news about what's happening in Washington. It can change, and it can change because of the will of the people and the voice of the people.
Absolutely.
But if they don't lift their voice, then the projections that we're hearing, if they come true, we're going to be in trouble. So lift your voice, let it be heard. So thanks for joining us today on this episode of Rural Health Today. And I would like to wrap it up, though. We do a new closing segment. And we used to ask, what was your most rural experience? We don't do that anymore. It's called Rural Health Recommendations, because what we want to do is we want to empower our listeners, young leaders, maybe hungry leaders. And we want to use your decades of experience, Carrie, as a mechanism for maybe teaching a lesson or giving some insight into a new leader. So would you happen to have, a recommendation on rural healthcare? How, maybe it's just a simple charge to keep up the good work, whatever it is. It could be a tip for someone new that's working in rural healthcare, or maybe some sage advice on thriving in a rural healthcare setting. And then we add this recommendation to our online guide, and many people review that. It's on our website, ruralhealthtoday.com. Carrie, what would be your rural health recommendation?
My recommendation would be not to underestimate the power of your voice, and to use it in telling the story of what we need to be able to provide care to our rural populations.
That's right. One of the things you taught us, you actually shared with Rachel a lot, who was our chief advocacy officer, really, as well as marketing. But, you told Rachel at one point, Rachel, you got to get to Washington. We will advocate for you, but it's important, we'll go with you, but it's important for your leaders to see you and to hear from you. Now, not everybody can do that. I understand that, but I do think there is value in linking up with the NRHA because you have an advocacy team and you're always willing. You went with us. You're willing to go to the different departments and legislators to lift up the voice. So you can reach out, to Carrie or her team. In the show notes will be some contact information. And I would just strongly encourage you to link up, have that conversation, take a partner with you. You may be scared. My first time in DC was a little intimidating, but then you get there and you're like, okay. And then after probably the 20th time, it's like, okay, you know what to do at that point. And sometimes it's just whatever face they're looking at the most, they remember the issue in DC. And so look to your great association at the NRHA. Look to leaders like Carrie who can lift their voice with you. You're not alone. And we would just ask that if you're struggling as a hospital today, that, we would ask you to reach out to them because there is help that is available. So once again, Carrie, thank you for joining us today. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcasts. And don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com. And make sure you've subscribed to show that you'll never miss one of the great episodes. Until next time, remember the power of rural. Thanks for joining us today. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so that you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.